My name is Robert Marcus. I'm a consultant haematologist. I qualified in medicine in 1977, started my training in haematology in 1980, and then got a first consultant job at Addenbrooke's Hospital in Cambridge in 1987. I stayed there for 20 years and then relocated to London to King's College Hospital in 2008, where I stayed until 2017, and then I retired from the NHS and now continue in part-time private practice. I started getting interested in lymphoma actually when I went to Addenbrooke's as consultant, because my previous positions, I'd done a research position at UCLH in thalassemia, which was a red cell disorder, where I was interested in iron overload. I then moved to Hammersmith Hospital in 1983, where I got a fellowship in leukemia, and then completed my senior registrar training at the Royal Free in 85-86. So really it wasn't until I moved to Addenbrooke's in 1987 when I had a lymphoma clinic to run with a colleague of mine, Michael Williams, that I started to get interested in lymphomas generally and follicular lymphoma specifically, because we were interested in Cambridge in monoclonal antibodies, and the first monoclonal antibodies for clinical use had been developed in Cambridge by Waldman and Winter and Riechmann, and they'd invented the Campath series of monoclonal antibodies, which first started to be used as a prevention for graft-versus-host disease, and then as intravenous infusions for the treatment of low-grade lymphoproliferative disorders. We found that they'd induced a reduction in the number of circulating tumour cells and shrank the spleen and reduced the number of tumour cells in the marrow, but didn't do much to shrink lymph glands. So there was a certain loss of interest in that area in Cambridge, and the initiative moved, I think, to the west coast of America, where the anti-CD20 antibody, which became rituximab, first started to be used in the 90s. And during that period, I got involved with a number of companies and the trials groups in developing monoclonal antibodies for follicular lymphoma. But before that, follicular lymphoma wasn't, I think, of great interest to many people, apart from I think there was a group at Barts which had a great expertise in follicular lymphoma. But the treatment was mainly simple alkylating agents such as chlorambucil, and there were a number of groups which had started to use interferon, and then for patients with refractory disease, they'd use stem cell transplantation. But there hadn't been any real innovations in follicular lymphoma until the late 1990s.